All right, let's get right into it. Today, we are tackling a really critical topic, type 2 respiratory failure. And here's the thing. This isn't just about getting oxygen in, it's about a fundamental failure to get carbon dioxide out. Okay, let's dive in. So, you've really got to draw a clear line between the two main types of respiratory failure. Type 1, that's hypoxemic. It's a gas exchange problem. Think of it like a faulty filter in your lungs that just can't pull enough oxygen into the blood. But what we're focused on today is type 2. And this is totally different. It's a pump problem. The entire mechanical system of breathing is failing, and that leads to a dangerous buildup of the body's main waste gas, carbon dioxide. So what are we talking about officially? Well, it's when that respiratory pump we just mentioned fails to ventilate properly. The direct result? Carbon dioxide starts to pile up in the blood. And the magic number we're looking for, the key marker, is a PCO2, that's the partial pressure of CO2, above 45. Here's our game plan. We'll start by really digging into why the pump fails in the first place. Then we'll look at the vicious cycle this kicks off in the body. After that, we'll lay out a really simple framework for how to fix it. And finally, we'll get into the practical side of managing the patient. Okay, so let's get right to the heart of it. Why does this pump actually fail? It really just boils down to an imbalance. It's pretty simple physics, actually, but with huge clinical consequences. Hypercapnia happens when the body starts producing more CO2 than the lungs can possibly clear. Production wins, removal loses. Now, this failure isn't usually just one thing. It typically happens along three main pathways. And the real danger here is that they often gang up on the patient, working together to push the whole system towards collapse. First up, we've got the most straightforward cause: you're just not moving enough air. We call this minute ventilation. And it's a really simple formula. How big is each breath? That's your tidal volume, times how many breaths you take per minute. If either one of those numbers drops, your ability to clear CO2 just takes a nosedive. And this quote right here, it's a perfect way to frame it. It just captures the clinical picture so well. When that central drive to breathe is turned down, you're dealing with a patient who, for whatever reason, literally won't breathe enough to clear out their CO2. So this breakdown can start in one of two places. Think of it like a chain of command. The problem can be central, up at headquarters. The brain's command center is suppressed by something like an opioid overdose. Or the problem can be peripheral, out with the troops on the ground. The muscles themselves are just too tired or too weak to do the work, like what we see in something like myasthenia gravis. Mechanism 2 is a little bit sneakier. It's what we call increased dead space. And this is basically just wasted effort. Air is moving in and out, but it's not actually doing any work. No gas exchange is happening where it counts. I mean, picture a lung that's been damaged by severe COPD. Huge parts of it are useless. The patient might be huffing and puffing, but their effective ventilation is plummeting, and that CO2 just starts to pile up. And that brings us to our third culprit. And honestly, this is the one that often gets overlooked because we're so focused on the lungs. Sometimes the pump is working as hard as it possibly can, but the body is just producing a tidal wave of CO2. This is often the tipping point, the straw that breaks the camel's back for a patient who's already just barely hanging on. So what kind of stressors are we talking about? Well, a raging fever, a body fighting off sepsis, even just violent shivering. But here's one that's a classic trap in critical care: overfeeding. If you're pumping a patient full of calories, especially carbohydrates, you can seriously crank up their CO2 production and completely overwhelm a system that has absolutely no room for error. Okay, so the pump is failing and the CO2 is building up, but what does that actually do to the body? This is where a bad situation spirals into a life-threatening crisis. We're about to enter the vicious cycle. Now, this is huge. It perfectly illustrates the critical difference between acute and chronic failure. I mean, look closely. Both patients have a dangerously high CO2 of 65, but the overdose patient's pH has absolutely crashed to 7.18. That's severe, life-threatening acidosis. Meanwhile, the patient with chronic COPD has a near-normal pH. So, why? It's because their body has had years to adapt. Their kidneys have been working overtime, stockpiling bicarbonate to buffer all that acid. And that is the crucial point. In an acute crisis, there is no backup system. The kidneys are just too slow to respond. And without that buffer, the blood's pH doesn't just drop, it plummets. And this is the number that should set off every alarm bell you have. Once the pH drops below 7.20, we are not just treating a breathing problem anymore. We are fighting a systemic collapse that is affecting every single organ in the body. The heart, especially, gets hit with a devastating 1-2 punch. At first, the high CO2 triggers an adrenaline surge, so the heart beats faster and stronger. But as the acidosis gets worse and worse, it acts like a direct poison on the heart muscle. That initial surge gets completely overwhelmed. And the result? Widespread vasodilation, a heart that can't contract properly, and then full-blown cardiovascular collapse. And at the same time, the brain is in deep, deep trouble. CO2 forces the blood vessels in the brain to expand, which just jacks up the intracranial pressure. This is what leads to the headache, the confusion, and you might see that classic sign, a flapping tremor in the hands called asterixis. If it's not stopped, the end stage is CO2 narcosis. The brain is so sedated by its own carbon dioxide that the patient gets drowsy, becomes comatose, and eventually stops breathing altogether. So that's the downward spiral. It's terrifying, right? But how do we pull the patient out of it? Let's pivot and talk about the fix. We need a simple but really powerful mental model to guide our every move.
And here it is. This is one of the most useful frameworks in all of critical care. At the bedside, you just ask one simple question. Is this a won't breathe problem or a can't breathe problem? If they won't breathe, the issue is central. Your goal? Restore their drive, maybe reverse an overdose. If they can't breathe, it's mechanical. Your goal? Remove whatever barrier is in the way and give those muscles a rest.
Now, what's our immediate goal? This might sound a little counterintuitive. It is not to wrestle that CO2 number all the way back to normal. The primary goal is just to get the blood pH back to a safe level, usually above 7.25. We call this permissive hypercapnia. We actually let the CO2 stay a bit high on purpose because aggressively cranking up a ventilator just to normalize that number can cause way more harm than good. All right, let's bring this all home and get really practical. In this final section, we're covering the how, the tools we use, the targets we aim for, and the critical traps we absolutely have to avoid. The workhorse for treating this is non-invasive ventilation, or NIV. For the right patient, like someone with a classic COPD flare-up, it's brilliant. It rests their breathing muscles and can help them avoid getting a breathing tube. But you have to know when to escalate. If that acidosis just isn't getting better, if their mental status is going downhill, if they can't protect their own airway, or their blood pressure is unstable, it's time to intubate. No question. Okay, this brings us to what might be the single most important trap to avoid. You have a patient with chronic CO2 retention, and they clearly need oxygen, so it feels intuitive to just give them a lot, right? Well, that can be a catastrophic mistake. So, what's the safe play here? The answer is a very specific, very narrow target. You keep their oxygen saturation between 88 and 92%. So why? Well, for years, their body has learned to ignore high CO2 as a signal to breathe. Instead, it relies on a backup alarm, low oxygen. We call that their hypoxic drive. If you come along and flood their system with oxygen, you switch off that alarm bell, and their breathing can slow down dramatically, making their CO2 level even worse. So we'll end not with a summary, but with a challenge, a question for you to take with you. For that patient who is teetering right on the edge of collapse, what's the subtle trigger that you could control to prevent them from falling off that cliff? Could you be more aggressive about treating their fever? Could you question that extra dose of a sedative? Maybe fine-tune their nutrition? Because often, stopping this crisis isn't about the big dramatic intervention at the very end. It's about managing these little upstream factors before that cascade ever begins.